chest centers across New York City. Can you elaborate on what services?
HIV counseling and testing and other services, and for a complete list of services, we do provide those online.
So what are the limitations in terms of services? By the way, I also would like for you to mention the new rapid testing that you're going to have for STIs, if you want to elaborate on that.
Yes. In terms of our limitations, we are proud of to offer an array of services that we provide at our clinics. There is a very particular role of public health clinics that meet certain needs with respect to that complement and meet gaps that are not filled by the healthcare delivery system, including the extensive public services that we're very fortunate to have through H&H. With respect to your other question regarding rapid testing for STIs, I actually don't. I think I'll have to get back to you on that.
Okay, that's fair. How many sexual health clinics are located throughout New York City?
There's 5 of the 8 sexual health clinics are currently operational. These are Chelsea, Fort Greene, Morsania, Jamaica, and Corona. The closed clinics are Crown Heights, Central Harlem, and Riverside.
Are there any plans to open more sexual health clinics?
Not at this time.
Okay. How many immunization clinics are there?
Currently, we have the Fort Greene Health Center, which offers immunization at no cost, regardless of immigration status, for all people for ages 4 years and older.
And the number of TB chest centers?
There are 4 chest centers at Morsania, Fort Greene, Washington Heights, and Corona.
Now, going back to the sexual health clinics, there's been, or it's been reported to us, there seems to be a little bit of a rise in HIV and AIDS, STIs, especially post-COVID, because you have a limited amount of sexual health clinics. Do you cross over and do work with H&H around that, or how do we expand services for people that need to be tested and get treatment?
That's a wonderful question. We certainly have many forms in which we try to align our services with H&H. Again, recognizing our role as a public health department vis-a-vis New York City Health and Hospitals as a healthcare delivery system. Certainly happy to have follow-up conversations about how to better align those and identify the gaps you're talking about.
Besides DOH, MH-run clinics, what are the benefits associated with having community health centers in multiple locations across New York City?
Another wonderful question. I think it's vital, especially at this moment in our city and nation's history, to have a physical presence of public health in neighborhoods, and so it's vital both for providing services and for our staff to have eyes and ears on the ground, listening to community members and being able to amplify their voices and help us do our job better.
How do community health centers differ from urgent care centers such as CityMD in terms of types of services offered? And I just want to express that what's upsetting to me is that in my community we have a number of urgent care centers like City MD, which when I go around and I talk to people in the community, they tell me that that's what they use as their primary care, as opposed to having a community health center. So that's why I'm asking that question.
Absolutely. And thank you for elevating this issue. The urgent care center ecosystem, if you will, is rapidly expanding in New York City, and I certainly think it's a very important healthcare delivery question. The idea of urgent care is that they provide some immediate services outside of an emergency department that enables more timely care and helps to decrease the burden on our emergency departments. Especially given as you have mentioned, the real inequities and lack of primary care centers in New York City, urgent cares do fill a certain gap for providing a number of urgent services outside of that our primary care system is not currently providing. And I think just your point about cost and affordability, it's certainly, again, I mean, this is largely New York State regulates this, but it's an enormous equity issue, both for safety net primary care providers who are trying to care for and provide medical homes, and are in a sense are competing with these urgent care centers, and also for the fact that many of the urgent care centers do not accept certain forms of insurance.
So how can access, again, sort of wrapping this line of questioning, how can access to in-community health care in any form be improved throughout New York City, especially in high-need areas such as health deserts? Hard questions.
Yeah, I would love to, would love to talk with this much more extensively offline with you all.
Sure.
I mean, I think just the one line here is, how do we all work together to make a more robust primary care system where every New Yorker has a medical home that your providers know you, and you have you can access those services in a convenient way, in a person-centered way, and at minimal cost to you as a user of those services. And as you well know, we have a very far way to go.
So I have in my district, and I have one of the highest number of older adults in the city, and older adult population is increasing. So how do you reach out to them? What kind of services? Do you work with DFTA around this issue? Because a lot of them don't have access, and these are the people that I'm talking to in my community that are going to City MD and places like that. So they need to have, especially with chronic disease, especially there are issues in terms of when one's getting older and everything else. So
yeah, no, it's another really important question. We certainly have a health aging unit at our health department, and we are collaborating with DFTA on a number of initiatives, and we're taking part in the cabinet for New York City's cabinet for older adults, and certainly our mayor and deputy mayor are prioritizing how do we different agencies work together on these very intersectional issues related to health and well-being and social safety, and we're very keen to continue that dialogue with you all and with our partners at DFTA.
yeah, one of the things I would like to do during my time in the council and as health chair is to try and pull all this together so that our seniors and everybody else, and including what Chair Narcisse had said about zip code, that we have to make sure that healthcare is accessible and affordable. So I'm hoping to work with you guys moving forward on that. I will now turn it over to Councilmember Barron to ask some questions.
Thank you very much. Do you all go to commissioner school on how to answer our questions? Because you always say, thank you for that question, what a wonderful question. All the commissioners say that. Do you really think all of our questions are wonderful? Or is it commissioner school that you go to when you address the council? Make sure you thank them for that question.
Thank you for that question.
Whenever I hear a commissioner say, I agree with the intent of a bill, that's a red flag for me. These bills, to me, are no-brainers. Even if you're doing equitable services, we're not doing enough. So whether it's about defibrillators or whether it's about vision care, I don't understand the just out-and-out support of the bill, not just the intent, because that really means nothing. It doesn't tell whether you are supporting the bill. You all usually say, I support the intent of the bill, but we need to have more discussions. And for these bills are so no-brainers to me that at least say you support the bill, and we'll talk about ways that we can implement these bills with some concerns we have. But at least say you support the bill. That's number one. Good question. Number two, how impacting is the mayor's cuts? You did get cuts to your agency, I think 3% across the board, correct?
I would have to defer to our OMB colleagues on that one.
You don't know whether your agency's budget was cut?
This panel doesn't have the budget information.
Excuse me?
This panel here doesn't have the budget information. I know we were here last week at our budget hearing.
You're assistant commissioners, right? So you don't know what your agency budget is and whether it was cut by the mayor or not? Come on now. Stop it. You were. And my concern is that we have the rhetoric in place, but the reality is that the dollars are not committed there. Even when you say we have a center in Brownsville to deal with the racism and one in the Bronx, and, you know, woefully inadequate what's happening in our community. That's lip service.
You've made more misstatements in a shorter period of time than I have ever heard.
This is Fort.
Please correct me if I'm worth $8 million.
Doctors is the emergency room for our communities. That's the primary care, the emergency room. These are deeply, deeply rooted racist problems that we have in our districts. And I just think that there has to be more meat, there have to be more in-depth commitment to resources. We do have a urgent care.
Excuse me.
All public.
Excuse me.
Yeah, go ahead.
All right. Excuse me.
Yes, sir.
If I'm worth $8 million, that's good news to me. I'm not aware of it. That's a lie. All right. Number
Part
two.
of public records.
You're probably looking at some phony right-wing internet stuff. It ain't true.
No.
All right. You should read beyond that.
Meeting the needs.
Now, that exchange very heated between Senator Bernie Sanders and Republican Senator Mark Wayne Mullen. That came during a hearing on Starbucks' alleged union-busting tactics. Howard Schultz is the star witness today, just days after he stepped down from his third stint as the CEO of Starbucks. He is there under the threat of subpoena from Bernie Sanders. CNN's Matt Egan has been following all this. Matt, that exchange, that wasn't even the main event. It was, you know, that was for Schultz to testify. So what did we hear on the Starbucks front?
Yeah, Alex, the main event really was Bernie Sanders confronting Starbucks founder Howard Schultz about his company's alleged union busting. Sanders didn't mince any words. He accused Starbucks of waging, quote, the most aggressive and illegal union busting campaign in modern history, and he noted that Schultz, the company's founder, only agreed to testify after being threatened with a subpoena. Listen to this exchange between Bernie Sanders and the Starbucks founder.
Let me remind you that federal law at 18 U.S. Code Section 1001 prohibits knowingly and willfully making any fraudulent statement.
I understand that.
Were you ever informed of or involved in a decision to fire a worker who was part of a union organizing drive?
I was not.
Were you ever informed of or involved in a decision to discipline a worker in any
Thank you,
way
Councilmember. I'm
who is
now gonna
part of
turn
a
it over to
union
Councilmember
organizing tribe?
Narcisse for
I was not.
questions.
Have you ever threatened, coerced, or
Good morning,
intimidated
and
a
thank you
worker
again,
for
Chair.
supporting a union?
I've had conversations that could have been
I
interpreted
believe in preventive care,
in a different way than I
because preventive
intended.
care can help us, right?
To make his point, Sanders pointed to a
Hypertension,
ruling from
affects
just
an
a few weeks
estimate of
ago
1.8
by a judge at the
million
National
adults in New
Labor
York City,
Relations Board who
and is a
found
leading
that
risk
Starbucks
factor for
displayed,
heart
quote,
disease
egregious and
and
widespread misconduct in its dealings with employees
must
trying
provide
to
New Yorkers. Wouldn't you say
unionize
that we
in Buffalo,
must
New
provide
York.
New Yorkers
Now, for his part,
with
Schultz,
every
he
available
repeatedly stressed that
resources
Starbucks
that we
has
can give
not
them to
broken the
keep
law. He
folks
also
alive
referred to these
and
allegations
maintaining their lives?
from the NLRB as just mere allegations, ones that he thinks will be
Blood-
disproven over
For the
time.
blood pressure, being a home care using them, we call them sphygmomanometer, right? Based on your knowledge and expertise, what can you tell us about the use of blood pressure monitors in the homes or in public places? Are they useful and or sufficiently accurate? Are you, familiar with the different type of personal blood pressure machine or sphygmomanometer?
Thank you so much, Councilmember Narcisse. And again, it's wonderful to have a council member who is a nurse and healthcare provider and advocate. So first on the use and utility of self-monitored blood pressure or home blood pressure monitors. Certainly, as you mentioned, evidence shows that measuring out of office blood pressure outside of a primary care clinic is a very useful way and important way to identify certain important types of hypertension, including white coat hypertension and masked hypertension. We believe that expanding home and self-monitored blood pressure is certainly a public health priority. We continue to work to address gaps and identify barriers to accessing blood pressure monitors in areas with the highest prevalence of hypertension, such as your own constituents. Limited funds do constrain our ability to expand access to home blood pressure monitors. And then your final question about the types of blood pressure monitors.
Are they useful?
Yeah.
So that I want to hear.
Yeah, they are. We agree that they're useful, and they're definitely an evidence-based component of comprehensive management of blood pressure by people who are living with high blood pressure.
But as a nurse, what we do, the doctors usually send a note for us to document the blood pressure throughout. Or sometimes, like if you're not seeing the client on a regular basis, they will have a home blood pressure kit. So when you're not there, for them to take their own blood pressure, because if the doctor have to make a decision in changing medication, they need to know what is the blood pressure, the average per each day. But since the nurse is not there every day, so they will have a monitor. So I find that they were useful. You find them useful. So which type of blood pressure machine that you will recommend for them to use at home?
We would defer that. The question about which specific type of blood pressure monitor, we would defer that to discussions between individual care seekers and their care providers, their nurse, clinicians, doctors.
So you're not familiar with them? With the blood pressure machine, the sphygmomanometer?
Well, as a clinician, certainly I am familiar with them. I'm just saying that I don't think that we as a health department are not recommending any particular brand or make of a home blood pressure machine.
Okay. What is the average cost of a blood pressure monitor? Would you know?
I mean, they're highly variable in terms of the end cost to user because it depends upon the brand and type, and then various electronic sort of bells and whistles but anywhere between $10 and $500. I mean, in terms of the cost to the user.
It's not that 10 to 5. But anyway, we can do more research on that one to see the average, because lately I have not been in the market buying them, but I know they're pretty decent, reasonable price that you can get a blood pressure machine. How often must blood pressure monitors be replaced?
That depends,
Do you know?
That depends on their use and the type of blood pressure monitor.
Averagely, can you take a shot at it? No? No. Okay, can you elaborate on the tools available through DOHMH Hypertensive Action Kit?
So thank you for that question. Our health department's Hypertension Action Kit provides resources for providers, including guides on hypertension management coaching, self-measured blood pressure monitoring, as we were talking about, and other references to support person-centered hypertension care. The kit also includes clinical tools for providers to educate and empower their patients, such as a plate planner, medication adherence assessment, blood pressure tracking card, and educational information regarding sodium intake. Finally, the kit includes patient education materials, including educational palm cards on salt, blood pressure, and posters on how to take one's blood pressure. All these resources are intended to support providers and help educate on blood pressure management, and they're available online.
Mm-hmm. You see the tracking you mentioned, the cards, those are all the things that the people can use too as well, like people at home.
That's correct.
Folks at home. Is there any information in the kit that relate to self-measured blood pressure monitoring?
That's correct.
Okay. If so, what information is specifically provided to the public?
Specifically, how one can take the blood pressure at home using a blood pressure monitor and safely and accurately interpret that.
Is there guidance on how to take your blood pressure?
Yes.
According to the DOHMH website, local data suggests that the rate of controlling blood pressure among patients diagnosed with hypertension is lowest among Black adults, 59%, compared to white, 73%, Asian, 73%, and Latino adults, 69%. How is DOHMH working to address the rate of controlled blood pressure among patients, particularly Black New Yorkers diagnosed with hypertension?
Thank you again for elevating this vital public health and racial justice issue. So two areas that we are in particular working on. One is, as I mentioned, through Take the Pressure Off New York, which is a multi-stakeholder coalition to address comprehensively hypertension prevention, screening, prevention, and treatment. And the second is that we work with a network of small primary care and primary care clinic and federally qualified health center partners in supporting their use of tools such as the Hypertension Action Kit and other tools to improve the quality of hypertension management that they provide.
Thank you. Does DOHMH have access to the locations of all public blood pressure monitors in New York City right now?
We do not. We do not.
Many patients suffering from hypertension have a difficult time finding a blood pressure machine monitor with a cuff that fits their arms. I always have that problem as a home care nurse. I always have to have a different one, right? Do you know what cuff size are available to the public and how they can access them?
Well, I can definitely, I definitely share the challenge there, both when I care for kids and for adults on this issue. There's sort of four main categories. One, the pediatric cuff, the the adult cuff, the large adult cuff, and the thigh cuff, and then a number of specialized ones that are used in different circumstances, particularly in the hospital setting. And again, the proper sizing of those cuffs we recommend to be in consultation with nurses and clinicians.
Consultation with the nurses. We're the one that actually take the blood pressure all the time, right? The doctors rarely do that. They only do it when the nurse is not around. Studies have shown that older adults are more likely to get inaccurate measurements from their at-home blood pressure monitors. Is DOH-MH working with the New York City aging population to ensure that they are properly educated on how to use the BPMs and how to read the measurement?
At this time, we don't have specific programming around that.
So, so now I hope that you can join me in what I'm asking for. Because when you don't know, individually it's so hard because people have different size of arms, but if you know that person, you give them that cuff, that measurement for themselves, you can automatically know how to measure. One of the things, from my experience, one of the experience that I have, when you go to take the blood pressure and they're borrowing from somebody else, it cannot fit, you cannot get a proper reading. You know that, right? If the cuff is not fitting right, the reading is gonna be inaccurate. So I'm hoping that you can join me, whatever that we can have the discussion to make sure that we address it properly, but it will save lives. That's what at the end of the day, all right? In helping keeping those folks that are at risk, because we know predisposition for all the disease, especially during COVID. When COVID hit, most of the folks that end up dying are the ones that suffer either heart problem, hypertension, diabetes. So therefore, hypertension, if we can address hypertension, you have more people right now walking around with hypertension that have no knowledge, no clue, every day, because it's a silent killer. That's what we call it. So I'm hoping that you can join me in addressing that, and that would be a start for us to keep New Yorkers healthy. Health is wealth. Thank you, Chair.
You're welcome. I'm going to ask, first I want to acknowledge we've been joined by Councilmember Gail Brewer, and she has some questions to ask.
Thank you. I'm sorry I was late. The issue that I'm concerned about with Councilmember Brannon is the pediatrics emergency room. And the reason this came up was I have two friends, a colleague and a friend. They have 3-year-olds, 5-year-olds. In one case, EMS came very quickly. The child passed out, was many ailments, panicked parents. Ambulance comes, and where do you want to go? Which hospital? Which is, I know I've been in an ambulance, they ask that question sometimes, and parents didn't know, so they picked the hospital where the child had been born. They get to the hospital, and it's not a pediatric emergency. I know they're supposed to take care of everyone, but the mother felt in 2 cases that it wasn't the appropriate place for a child, even in the ER. What the mothers would have liked would be a list of the pediatric emergencies where they could have gone, where they felt they would have gotten better support. Sometimes the hospitals are right near each other. This particular ER told them to go to the pediatric elsewhere. So we need that list. It doesn't exist. So my interns are fabulous, and they made a list of what they think the pediatric emergency rooms are, but there's no such list. So I'm just wondering, is that something that, with this kind of information, sharing it with 311, whether you think that would be a good idea? Like I said, and then it would be circulated to the schools and mom emails and so on and so forth. And I didn't know if you think it's a good idea. And then I think we do need to understand the difference between a pediatric ER and emergency rooms. I must admit, my kids are older. I didn't know that there was a difference. I thought it would all be the same. That is not how parents feel. And actually, that's not how doctors feel, interestingly enough. So I'd like to get your input.
Thank you again for your passion for this issue. I'll share just as a, just fairly recently, as a pediatrician at Elmhurst, again, I had a situation that also highlights the need for the importance of pediatric emergency rooms and what their role is. For many years prior to coming to New York City, I was a complex care pediatrician, which cares for kids with various developmental and other complex medical needs. And those kids, as we were talking about regarding primary care, really need a very comprehensive medical team, clinical team, that interdisciplinary team that cares for all of their needs. And so we admitted a child who had these sorts of complex care needs. And we were talking with the father, who happened to be Spanish speaking, and he said, I have this issue with my G-tube, the gastrostomy tube, because my child doesn't eat, so he has a G-tube. And I have this issue, and whenever I can't bring him to the hospital, so I have to call EMS. And so then I call EMS, and they say, because you live in the catchment area of Elmhurst Hospital, and you have to go to Elmhurst Hospital, which we do have a pediatric emergency room. We do have a pediatric inpatient room, but his care providers are actually at Cohen's, out towards Outer Queens, towards Long Island, which they have all of his primary care providers. And so, I said, look, his dad was just like, I want to talk with my GI doc. I want you guys to be able to coordinate care. So can you transfer me to Cohen's? I said, absolutely. And we arranged for that. And I wrote him a letter that said, doctor's orders, when EMS comes, hand this to EMS and say, take me to Cohen's. So I think that this issue has many different layers to it. And I applaud you for elevating it. I think, there really is a vital role of pediatric emergency rooms. And I'm not just saying that as a pediatrician. I really do. As a parent as well, I do think it's vital. In terms of how do we get the word out about these? One is that really what we recommend to parents is that that you call 911 and EMS direct as appropriate, because in an emergency they have to take you to really the nearest emergency room, and they can transfer you, as in the case I talked. I think the other piece is that there are New York State, which regulates clinical care. They do maintain a website of pediatric facilities. And so, I think what we want to just ensure is that that this is timely, up-to-date, accurate information, that's not conflicting with other sources.
Well, these are very sophisticated parents. They know nothing about the state list. So, I think the city should have the same list, and then there should be a law that says you publicize it, because one thing to have a list on the website, but if nobody knows about it. This ambulance driver, and they're all great, said, where do you want to go? I've had that too with my kids. Where do you want to go? So, I don't know. I think people should know that there are choices when you have a baby, basically. And it's, to transfer is heart-wrenching also, because time is of the essence. These parents were totally panicked. So, I just think we should have a much more robust information than what we have now, because nobody has told me, this is my negligence, but certainly these parents are, type A's, as we call them, and they didn't know a thing about the state list, if there is such a thing. And I have a list from the interns. Elmhurst is on it, obviously, but no addresses. Nobody knows what you know. And so the question is, what can Department of Health, is that something that you think you would do in terms of publicizing, working with DOE, et cetera, and keeping it up to date on both state and city? Is that something that you would consider? That's my question.
Yes, thank you for that, and certainly happy to discuss further sort of the intent and how we get there.
Okay, thank you, Madam Chair. I'm very concerned about this issue, so thank you.
No, absolutely. I'm going to turn, I have some more questions, but I'm going to turn it over to Councilmember Krishnan to ask his questions.
Thank you so much, Chair. Just a few questions on Intro 814 on AED access. So as we know, the bill would require DOHMH to issue a report on the number and location of AEDs in public places. Does DOHMH currently have a framework or list of the location of all AEDs in New York City?
We do not.
Do not, right? I'm sorry.
Not correct.
Does DOHMH distribute free or low-cost AEDs to public institutions and spaces like schools, houses of worship, nursing homes, not-for-profit organizations, or parks?
We do not.
Is there an existing system that keeps track of the number of AEDs that have been issued and to whom?
There is not.
Is there an exact number or estimate on how many AEDs are currently available in public places in New York City?
There is not.
Is there a maintenance system in place to regularly check on the condition of AEDs?
There is not.
So I would assume that we don't know then how many AEDs are in good working condition and ready for use in the event of an emergency.
We do not.
What maintenance is typically required for AEDs to make sure they're kept up to code and ready for use?
That's a great question. We don't have guidance on that, and we don't, because we don't monitor or collect information on AEDs. And certainly happy to discuss more with FDA, with you, and with fire department and emergency medical services on that topic.
Sure, thank you, Assistant Commissioner. Those are my questions, but I just want to end by saying, given all of that, I think the urgency and the need for this legislation to be implemented is very high. I do agree with Councilmember Barron that these bills are all bills that we should be moving forward expeditiously. We don't want, God forbid, another emergency crisis in the city where resources could have been available, life-saving devices, but we as a city don't have any clue as to how many are maintained, whether they're in good working order, where they're maintained. So I do appreciate your testimony, but it's my priority to make sure that this legislation both moves quickly and is implemented quickly. So I know there are things that we want to talk about and discuss as well, but I don't want it to slow down the process because, as we know, these are life-saving devices, and we as a city have got to do a much, much better job of tracking them, making sure they're in good working order, and finding out places where we actually do need them or they don't currently exist. And so, given that we don't have any of those systems right now, it's clear that this legislation fills a glaring void in our healthcare access for such a crucial life-saving instrument. But I know that you all, under Commissioner Vasan and Assistant Commissioner Maru, I know you all are very committed to this, and that healthcare access is a top priority for you all, and finding any way to the data is especially important to you all too. So I look forward to us working together to make sure that we can implement this as quickly as possible.
Thank you.
Thank you.
Thank you, Councilmember, and I want to echo what Councilmember Krishnan said about the AEDs. I used to work in a past life at the with the emergency medical service, so they do look at them now. That's part of FIDNY. They look at the AEDs. One is that I will tell you that I know from experience that a lot of them are not checked regularly, so we're going to have to deal with that. And we also, it is important to have a list of where they are, and so that people can help to maybe save a life here and there. So I think that that's very important. I will also say that I worked at Woodhull Hospital, so at H&H, and to Councilmember Brewer's point about pediatric EDs, we had a pediatric ED there, and it does make a difference. The instruments are different, the care is different, not that it's different, that you get better care one way or the other, but it's a specialty area, so that if you have a child with some acute issue, it's not always picked up in the regular ED. So to that point, I want to echo what the council member said. And then going lastly to the blood pressure issue, I'm technically an older adult, and when I will tell you that when my blood pressure is checked by a machine, it's 20 points higher always than when it's done manually. And so I think that people really need to be educated, and I'm pretty educated and have been working in healthcare for a very long time, about how that works, whether we should be alarmed or not alarmed, because I could take it one place and it's perfectly normal, and in another place it's high. So I don't know how that's calibrated on the machines. I don't know how we get word out to folks, especially older adults. So I'm asking the question.
Yeah, thank you for that. Can you can you clarify your specific question?
My question is, how do we educate people on when they get their blood pressure taken or they get a screening, whether that's an accurate reading or not, and how can they determine if it is? Like I said, the machines sometimes are not calibrated right, depending what you get, what you don't get. If you buy one, some of them are better than others. Some of them have a very vast error rate. So that's the issue. And then I'm just curious as to why there's a difference between taking the blood pressure manually and doing it with a machine, because the tendency is, and I'm told the machines are calibrated higher.
Yeah, absolutely. Yeah, I mean, I think I very much acknowledge and appreciate your experience here with respect to the discrepancies between different forms of manually and also different forms of automatic blood pressure cuff measurements. And I think it really does, again, highlight the importance of education, as you mentioned, and work with improving primary care access, because really having consistency, high blood pressure monitoring and management is really, for many of us, is a lifelong endeavor, whether we have diagnosed hypertension or not. And so having consistency and regularity within the primary care system is vital. And certainly happy to discuss more how we can work on some of this, the specific issue of the accuracy and reliability of these different machines with both the TPO, the Take the Pressure Off program, and the NYC REACH program.
No, and I also think it's important for doctors and everybody that takes blood pressure to sort of be educated about how to do it, because when I'm reading stuff, I read that you're supposed to be quiet and sit still, and your arm's supposed to be elevated and all this other stuff, and that never happens in a doctor's office, never, ever, ever. So I think there needs to be an education. I know that the state does that with, has responsibility for that with physicians, but I'd like for DOHMH to work with the state on really clarifying and educating the public, and that my colleague is smiling, about what is involved here, and so that we can really have people be healthy and be confident in that when they're getting a reading, that it's a certain way that, because I will tell you that a lot of the medications there are for blood pressure are not the greatest either, and there are side effects to it. So it's a question of what is it that we have to do, and are we getting good readings from, just in general, like what the practice is, what the standard should be, and everything else. There's a lot of confusion out there.
Absolutely. Thank you.
I need to spend time with my colleagues on that one. We're going to do that.
Okay. Thank you. I don't have any further questions. Does anybody else? Thank you very much for coming to testify today. We really appreciate it, and we'll follow up.
Okay, that concludes testimony from the administration. We are now going to move to public testimony. So what we will do is we will start with public testimony from folks who are in the room, and then we will move to virtual testimony. Just a reminder that if you are submitting written testimony, you have up to 72 hours after this hearing to do that. You can do that at testimony@council.nyc.gov is the email address. And also just, yeah, so why don't we get started then? We will start with the first panel. We're going to be hearing from John Flanagan and Dr. Neil Shipley. And then just a reminder to speak clearly into the microphone, and you'll press the button, wait for the red light before you begin your testimony.
All set?
You may begin.
All right, good morning. Thank you very much. Very nice to be here. Quite educational to be able to listen to the preceding testimony. And drew my attention to a lot of issues, but my name is John Flanagan. I serve as Senior Vice President for Government Affairs at Northwell Health. And I'm joined today by Dr. Neil Shipley. Dr. Shipley oversees our Go Health urgent care facilities, and Dr. Shipley is our medical director and our radiation safety officer for all of our Go Health urgent care facilities. And I just want to give a shout out to Councilmember Krishnan in particular on AEDs. In a former iteration of my life, I got a chance to work on very extensive legislation that came out of constituent work. A family, the Akamporas, lost their son many years ago to a tragic lacrosse accident, and they were the genesis for changing the state law, and a lot has happened since then. So that's one thing I very keenly understand. That said, we're delighted to be here. I want to thank all the members, the chair in particular, but all the members of the committee for affording us the opportunity to speak on the issues that are before the committee today for their consideration. And I'm wholly mindful that you're in the middle of the budget process. The fact that we would be able to be here is equally helpful. I'm going to speak very briefly and then hand it over to Dr. Shipley, just in terms of community care and urgent care in particular, and how we run our operations and the things that we focus on. Our CEO, Michael Dowling, is heralded as a national healthcare leader, was voted as the #1 healthcare leader in the country, and having worked very closely with him, it's about mission, it's about access, about equity, and about excellence. And I know that factually because I talk to him all the time, work on issues with him in our hospital-based settings in particular, of course, but outside of that, if you were to ask about Northwell as a system, there's a lot more that happens outside the hospitals than happens inside the hospitals, and about 55% of our revenue comes from outside the hospital. The point we want to talk about today relates to urgent care for efficient operation, flexibility, how we serve people in their time of need, how we try and avoid people coming to the emergency department unnecessarily, and it's all with an eye towards getting out into communities and providing the best care possible. Very confident that Dr. Shipley can articulate it extremely well. He's got decades of experience and is our frontline person on issues involving urgent care. Dr. Shipley, and thank you again.
Good morning. My name is Dr. Neil Shipley. I've been a New York City resident for about 35 years. I'm board certified in emergency medicine. I've been practicing in emergency medicine and urgent care since 1993. In 2021, I had the honor and privilege of being sworn in as a New York City honorary police surgeon for our work with the police department in support of the COVID pandemic. For the past 7 years, I've been the medical director for a large health system, Northwell Health System affiliated urgent care network. We have 20 sites located in New York City. As we know, urgent care centers play a very important role in the New York City healthcare system by improving access and equity of care for thousands of New Yorkers. EDs in New York City are generally overcrowded, long wait times, access to PCPs can be challenging, and the cost of an urgent care visit is something like 4 or 5 times less than the cost of a visit in the emergency department for the same condition. Prior to the urgent care model, really the only place New Yorkers could access immediate unscheduled care was the ED. Another example of the role that urgent cares can and we hope to play in avoiding unnecessary ED visits is the upcoming launch of our partnership with CMS and FDNY in a program called ET3. ET3 stands for Emergency Triage, Treat, and Transport. It is a federally sponsored demonstration project that will go live in 2023, and it will allow FDNY EMS crews to bring patients to alternative destinations. Lower acuity patients can be brought directly to the to the urgent care center instead of the emergency department for diagnosis, evaluation, and treatment. We are very closely aligned with CMS and FDNY on the importance and impact of this demonstration project for New Yorkers. The specific regulation we're discussing today regarding the use of mobile x-rays in the urgent care center is very problematic for us as a business. Is it okay to continue? Thank you. And for our ability to serve this purpose for the New York City community. Our centers were designed to be small, to penetrate retail spaces and be close to public transportation hubs to give patients best access. The cost of the facility modifications alone to convert our sites to fixed x-ray rooms would be a big economic hardship for the business. But more importantly, in having to do so, we would have to eliminate at least 1, probably 2 of the existing exam rooms in all of our centers. That would dramatically reduce our capacity and throughput and the ability to see patients and provide them with alternative destinations to the emergency department. I'd like to spend the rest of the time here talking about our quality and safety program for the mobile x-rays. We've been performing them in our centers since we first opened in 2014. Our priority has and always will be patient and staff safety. Since 2014, in our New York City-based locations, we have performed over 72,000 mobile x-rays. We have a rigorous quality control program that is comparable to the ones in place in hospital EDs and inpatient units that also use mobile x-ray. I'm going to just highlight two of those programs. Since 2014, no staff member radiology technician has ever received a radiation exposure that reaches or exceeds the maximum occupational dose for either quarterly or annual exposure limits. The folks before us from the Department of Health talked about the ALARA principle, as low as reasonably acceptable. We have never exceeded that once since 2014, 0. The other thing that was spoken about is what's called the RR analysis, or repeat reject analysis. Repeat imaging due to improper technique is a leading contributor to unnecessary radiation exposure. The standard for this is less than 5%. We do RR analysis quarterly on all of our units and all of our sites. Our performance is well below that. We are consistently at or below 2.0% of images that have to be repeated or rejected due to quality. That is comparable to the RR rate that is observed in Northwell inpatient and hospital-based units. So let me sum up here. We do appreciate the regulatory intent behind this article. Patient and staff safety is our highest priority. But we believe there's a way to preserve that intent by granting waivers to urgent care centers to continue to perform mobile x-rays if they adhere to the similar quality and safety standards that you can find in the hospital setting. We have a very long track record of excellent patient and staff safety. We have a robust quality control program that meets or exceeds all recognized standards. And without our ability to do mobile x-ray, a significant portion of those 72,000 patients would have ended up in an overburdened emergency department or potentially deferred care, leading potentially to worse outcomes or higher costs of care. So giving this ability will help us support this mission of increased access and equity to care for all New Yorkers. So thank you for the opportunity to speak to you on this important issue today, and we're obviously open to answer any questions.
Before I have a couple of questions, but before I do that, I want to recognize my colleague, Councilmember Areola, who wants to ask some questions.
Hi, thanks so much for coming to testify today. So I have one question. Do you have any recommendations for the best way to expand care in communities outside of the hospital setting?
The best way to expand care in any communities? Look, we're not in competition with primary care offices. We complement them. We're open when they're not on the weekends and evening hours. I think a comprehensive focus on, access to primary care is critical for communities. I think access to urgent care, to unscheduled walk-in care should be part of that sort of overall picture. So I think it's a kind of a triad. You need to have a great public health system, public health departments. You need to have a robust emergency department, and you need primary care. Urgent care fits into that space between primary care and the emergency department. Lower cost, easy to access. You don't need to make an appointment. Most of our patients walk in on the same day. The visits last 45 minutes to an hour. They cost a fourth or a fifth of the emergency department. So I don't think there's a one-size-fits-all solution. I think it's a combination. It has to be multifactorial.
Thank you very much.
I'd just add to what the doctor said. We're asking for specific relief in the overall view of healthcare, and I think what we're looking for, if you can perform these services in somebody's home or in a long-term healthcare facility, you can perform these services in urgent care facilities outside of the city of New York. You can perform them in hospitals all throughout our region. We have zero issue with the notion of standards, strong oversight, regulatory review, and we adhere to that. And as Dr. Shipley said, we have 100% compliance. We've never had an incident. Our specific ask in terms of the global stuff as well is to say relief here would be very important to our patients. And I would reiterate, we hold our employees to the same standards that we do our patients, meaning that we want to do every single thing possible to protect them. This relief delivers better patient care. Thank you.
Yeah, I just want to say thank you, and we'll take this in, and we have, if you, Doctor, I don't know if you summarized your testimony, but you can submit the whole thing, because it does get looked at by the committee and everybody else, and the central staff. I do want to say that I have, in my district, I have Northwell Forest Hills, and I work closely with them, and the CEO there is great, and so we're trying to do what we can, and I've used the urgent care as well. I just want to be on the record, Northwell Urgent Care. And so, and gotten and received good treatment there. But I do want to say, one of the things I do want to suggest is to talk to the Department of Health and Mental Hygiene. I'm sure that you've gone to them already, but I think that they would be willing to work with you and try to come to some kind of compromise. But, you know, so that's just a suggestion I want to make. But I do want to thank you for coming here and giving the testimony. You do? Okay, I'm going to turn it over to my colleague, Councilmember Narcisse, so she has a question.
I'm trying to understand. Do you have urgent? How many you have? Do you have urgent health care right now that you work on?
There are 20 in the New York City boroughs. If you expand the entire size of the footprint, includes Westchester, Nassau, and Suffolk, we have 57 urgent care centers, but 20 are located in the New York City boroughs.
Okay. How many clients that you see per year, last year?
In New York City boroughs, about 320,000. Across the entire network, about 950,000. Again, in 2021, slightly over 1 million patients. During the pandemic, we did about 500,000 COVID tests in the New York City boroughs. We diagnosed about 70,000 patients with COVID, treating them and keeping them out of the hospital emergency department, flattening the curve. So I don't know if that is answering the question.
No, it's answering the question.
Okay.
Where are you most, I mean, my question is just, I want to see how you strategically place them. Where they're throughout Brooklyn, different zip codes, different place in Queens, how you plan to put them?
Yeah, I mean, we have a list which we can submit.
How you decide, my question should be, how you decided where to place urgent care?
Yeah, so I'm the medical director. I'm responsible for clinical quality and safety. I don't make the real estate decisions. I know that we are in, in the New York City boroughs and Westchester and Staten Island and Manhattan and Queens and Brooklyn. But again, I don't play a role in deciding the locations of the centers. My job is to stay focused on clinical quality and patient safety.
Because I know a lot of people use urgent care, so thank you for your time.
Councilmember, I'll take a stab at that if it helps. We, our GoHealth operations, the urgent care centers, are a joint venture with Northwell, and I think it's viewed in the context of a couple of different things. Where's our footprint? Where are we growing? And unlike a lot of other healthcare systems, we are continuing to expand. So we have close to 900 facilities outside of the traditional hospital setting. And that's ever evolving because of the evolution in healthcare generally, insurance reimbursement, issues like that. And some of it is healthcare component in terms of where are we providing services, where do we see healthcare desert, so to speak, and what are we trying to do about that? So it's a healthcare perspective combined with a business review, and we can absolutely send you a list of the facilities that we have, and you can let us know what you think.
Thank you. Thank you, Chair.
May I say one other thing? The previous folks who were sitting at this table had some comments about insurance, and I just want to be clear, we accept every insurance that the health system does, including Medicaid, Medicare. So again, we believe our centers do improve access and equity to care. And again, reflecting on our strong track record of patient safety and quality, we think that this relief would help us continue to preserve that mission for New Yorkers. Thank you.
And thank you. I have no other questions unless, Gail, do you?
Dr. Shipley is my neighbor. I have no questions. Thank you.
That's a good thing, Doctor.
What happens in the Upper West Side stays in the Upper West Side. Yes, Gail?
All right. Thank you very much for your testimony. We appreciate it, and, you know, we'll certainly work with you to see what we can do to make sure that everybody has access to the healthcare they need. Thank you.
Thank you very much to this panel. Next, we'll be hearing from Greg Mihailovich, please.
Whenever. Are we ready? Okay. Hi. Thank you for the opportunity to be here. My name is Greg Mihailovich. I'm the Community Advocacy Director for the American Heart Association here in New York City. I'm very excited for the topics of today's hearing. AHA is the nation's oldest and largest voluntary organization dedicated to fighting cardiovascular disease and stroke. And we talked a lot about CPR and AEDs. We're very excited for the topic because CPR saves lives, AED saves lives. And I just wanted to comment a couple of things. I won't go into the stats because everyone covered it, and I'm going to use my 2 minutes, efficiently. With Intro 975 with the CPR classes, yay, we love it. Just a little clarity about training versus certification, because we get that kind of question where training is practicing compressions and situational awareness, where certification is actually like rescue breaths, and also specifying where child and infant CPR classes are, because those are different, and a lot of times they're included in parenting classes, but not always. Intro 814 with the AED reporting. Again, there's some clarity there. Happy to see that Councilmember Krishnan was talking about like upkeep and how often they're doing. But to your point, Chair Schulman, for children, over the age of 8, you can use a standard AED, but 1 to 8, you have to use pediatric pads or AEDs that might have a kid switch that reduce the voltage, and children, under 1 have to use, manual defibrillators. So clarity on what's available there. And then for the PP kiosks, we're a big fan of Take the Pressure Off NYC. We're on the steering committee, so we're very excited to see this kind of renewed focus. But the kiosks, I think, are kind of an old school way of doing things. I mean, we talked about how self-monitoring blood pressure at home is a validated approach to managing your blood pressure. And the kiosks that were placed, it's funny, you asked where they were. I actually printed the city's maps where they were placed. And I'm happy to share it with the council. I just didn't want to share it before there. The placement was a little uneven. So there were 4 on Staten Island, none on the North Shore, which is, lower income black and brown communities. I think there was only 1 in your district, Councilmember Ariel. I think there was only 1. There was only 1 north of 181st Street. So kiosks may not be the best way. So we would definitely support ways that we can get BP cuffs into the communities with community partners, local health clinics for distribution, so people can monitor their blood pressure safely at home. And I can leave this if people actually want to see the maps. It's just city. They put it directly. Oh, and most of these places have closed, by the way. The Rite Aids and everything was closed.
We'll take it and we'll make sure that we document it.
Yeah. So thank you for your attention on all this. Any way we can be a useful partner, we're happy to assist in any way we can, and thank you for the time here today. Yep.
So you encourage the blood pressure to have the machine at home?
Yeah. I mean, the kiosk
is the only one.
Yeah. No, we think. I mean, in the DOH, the doctor from DOH chambers talked about like the white coat syndrome, where people are tense. And the idea that, you're a nurse. I feel like I shouldn't be saying this to you. The idea that in more relaxed they can do this. And I mean, for personally, we're also seeing this like greater reliance on remote care because of the pandemic. People are having their Zoom meetings with the doctor, just like we always said that people should have thermometers at home or the O2 monitors. The idea that having your blood pressure cuff at home really helps you manage your numbers a little better. So they talk about like it's covered by insurance. Not everyone has insurance. Not everyone's insurance covers it. So the idea of figuring out a way that we can get the cuffs into the hands of people who need it, who maybe aren't going to take a bus and travel for an hour to the nearest pharmacy that has a kiosk, we think is meeting people where they are, and it really helps people have that kind of health equity issue. And we'll happy to talk with you more about this.
Okay. Thanks.
Thank you, Councilmember. Councilmember Ariola, do you have any questions? Okay. Thank you.
Thank you very much to this panel. We're now going to call up Richard Flores, please. You can proceed when you're ready.
Hi.
You ready?
Yeah. I read on the website that they were covering providing vision testing and eyeglasses to low-income individuals for residents whose annual gross income is within 250% of the federal poverty level. Is that correct?
That's correct.
Okay. I wanted to testify simply on behalf of a personal reason that I think that the healthcare system is failing. Regarding the urgent care centers, I have to be honest with you, I've never ever gone to the urgent care centers. I've always thought that the better route, despite the budget reasons that you discussed, was simply to go to the hospital to get care and not have a nurse or someone else see me and then refer me to a hospital. I currently have Empire Blue Cross Blue Shield as my insurance, and I have Medicare and Medicaid. So I have Part A, Part B, Part C, and Part D. I went to the eye and ear infirmary last Monday simply to get a test for my vision. I'd like to be really blunt here, and hopefully you can use this data for what it'll be used for later. Councilmember Barron made a few remarks about discrimination and racism in the system and how that's impacting upon the system. The ophthalmologist I saw was this gentleman, Dr. Aaron C. Brown, at the Eye and Ear Infirmary, and he conducted the examination. What I'd like to say for the record here was that he did a very, very poor job of examining my eyes in the room. He didn't tell the truth about any pre-existing conditions that I have.
If you want to make a statement just about, in general, about the healthcare, but if you're talking about a specific doctor or individual, we can't entertain that here.
Right. Well, I thought it would work in conjunction with making the testimony. What I've seen, what my personal experience has been, is that there seems to be an endemic corruption in the healthcare system, and I'm sure I'm not the only person that's experiencing it. That's even with the COVID-19 health crisis and other pre-existing conditions that people have. And I think that what that's doing is that's making the system work harder and spend more money, and more individuals are sick and more people are ill, as everyone knows, as a result of the fact that the system seems to be not working correctly. The budget proposals that you people make and the policy decisions that you make, understandably, I don't know its full complexity. You know a lot more than I do. but I thought simply using my experience, you could use that for your data and all the other individuals that are impacted. And I just wanted to use that example of that. I find it just really kind of strange, to be honest with you, as a civilian, as a citizen of the city, that the committee understands and has knowledge that this kind of thing is occurring. And my question to you, I'll stop here, is what are you prepared to do about it? If you can do something about it.
This is a hearing for you to just give your thoughts on, not to, we have a process here in the city council. You should contact your local council member, whoever that is, to talk to them specifically about going through that with them. And we appreciate you bringing us the testimony just about the particular place that you were at, and so we'll take that in. We just can't, talking about individual doctors or individuals in general is not appropriate for this forum. But we'll take in what you said, and I encourage you to talk to your local council member who can go through the process with you. Okay, thank you.
Thank you.
Thank you to this panel. At this time, if there is anyone left in the room who would like to testify but has not done so yet, please fill out an appearance card and give it to the Sergeant at Arms. Seeing none, we are now going to move to virtual testimony. We have, I believe, one registered panelist. So we're going to hear from Dr. Joseph Tolano, please.
You may begin.
Can you hear me?
Yes.
Great, thank you. And also I want to thank you for promoting me to doctor. I am not a doctor, but I appreciate that. Nonetheless, lofty goals for one day, maybe. But thank you to Chair Schulman and to the committee for the opportunity to provide testimony today. My name is Joe Tolano. I'm a senior policy manager with Primary Care Development Corporation, or PCDC. We're a nonprofit organization, U.S. Treasury certified CDFI, founded and located here in New York City. Our mission is to create healthier and more equitable communities by building, expanding, and strengthening access to quality primary care. Since our founding in 1993, PCDC has leveraged more than $1.4 billion to finance over 218 primary care projects, helping to provide 4.6 million medical visits annually and creating or preserving more than 19,000 jobs in low-income communities. Regular access to primary care is internationally recognized as a key social determinant of health and is associated with positive health outcomes, especially when addressing common chronic conditions like heart disease, the leading cause of death in New York. Primary care reduces overall healthcare costs and is the only part of the healthcare system that has been proven to lengthen lives and reduce health disparities. PCDC urges the council to center primary care in its efforts to increase access to in-community healthcare. PCDC also encourages the council to ensure that each health proposal within the budget prioritizes and includes primary care providers, patients, and the workforce. More details included in my written testimony, but we also urge the council to increase investment overall in primary care and to advocate for related state policies, including restoring the city's Article 6 reimbursement rate to 36%. As we continue to navigate the COVID-19 pandemic, the city must think critically about the role of primary care in its resiliency efforts, planning for future public health crises, and accelerating efforts to address health disparities that have been exposed. Relating specifically to primary care access in the city, PCDC's own research has indicated the critical role of FQHCs in improving and protecting community health. In 2021, PCDC conducted research on the role of FQHCs on COVID outcomes and
Your time has expired.
No, keep going. Go ahead.
Great. Thank you so much. Appreciate that, Chair. In 2021, PCDC conducted research on the role of FQHCs on COVID outcomes and concluded that FQHCs helped reduce community-level COVID-19 mortality. We encourage the council to conduct a study of existing FQHC locations to identify whether some areas would benefit from additional facilities. Much is already known about primary care providers' role in the pandemic response. More than a decade ago, during the H1N1 crisis, PCDC worked with Jacanes, DOHMH, and City Emergency Management to develop the Primary Care Emergency Preparedness Network in New York City, and various studies suggest that a similar network would have supported a better pandemic response this time around as well. Despite this, the primary care sector was largely left out of the early COVID-19 planning, service delivery, and mitigation efforts. Eventually, FQHCs were included in the federal vaccine distribution plan, and PCDC was grateful to play a role by providing pass-through federal funding to FQHCs to support vaccine outcome outreach and distribution. With much appreciated support from this council, PCDC also undertook research regarding access to primary care and the impact of COVID-19, and determined that communities with less access to primary care before the pandemic experienced more COVID-related illness and deaths than communities with better access. My written testimony includes more details and links to the City Council Primary Care Access Dashboard, and we'd be happy to provide additional information. We encourage the council to support a thorough review of primary care providers' experience throughout this pandemic. We also urge policymakers to ensure that spending on primary care and preventative services meets the demands of their communities so that people can lead healthier lives. We welcome the opportunity to work with the Health Committee and the Council to expand access to primary care for all New Yorkers, particularly those in disinvested, underserved communities. We thank you for your consideration of our recommendations and happy to answer any questions.
Thank you. I don't have any questions, but we appreciate the testimony.
Thank you, and I appreciate the extra time.
All right, thank you very much. At this time, if there's anyone else who would like to testify virtually, but has not had their name called, please indicate that you would like to testify using the Zoom raise hand function. Seeing no hands, turning it back to the chair for closing remarks.
So I want to thank everyone today. You know, as I said earlier, healthcare is a human right, but we have to get some of the basics down. So we're going to be making sure that DOHMH and other agencies within the city come together so that we can have a cohesive health system that takes care of people regardless of their status, regardless of their finances, and regardless of their zip code. And with that, I am adjourning today's hearing of the Health Committee. Thank you.